Okay, let's dive into this. Welcome to the Explainer. If you're gearing up for the MSRA, or honestly, if you're just wanting to sharpen up your everyday clinical practice, you are absolutely in the right place. Today, we're mastering a topic you're guaranteed to run into, both on your exams and, for sure, in your daily clinic. We're talking about acute bronchitis. We're going to break down the guidelines, completely bust some of those deeply ingrained clinical myths, and make sure you walk away with nothing but high-yield, purely evidence-based knowledge. So picture this. You're sitting in your clinic room, right? An anxious patient walks in. They've had a cough for, let's say, 10 days. And today, they've noticed their phlegm is bright green. They are absolutely convinced they need antibiotics and they want them right now. This is the ultimate clinical trap. We have literally all been there, and it is a scenario the MSRE examiners absolutely love to test. So what's the actual reality here? Does that colorful sputum actually mean they have a bacterial infection? Well, here is the massive punchline you need to remember. Greater than 90% of acute bronchitis cases are viral. Over 90%. That means for the vast majority of the patients you're going to see, antibiotics are completely useless. It's viruses like rhinovirus, influenza, RSV, and adenovirus that are the true culprits here. So what about that green or dark yellow sputum? It is not bacterial. It's actually just caused by normal neutrophil breakdown and cellular debris as the body fights off the viral infection. So here's our clinical pathway for today. 1. The bronchitis reality check. 2. Spotting the red flags. 3. Antibiotic stewardship. 4. Bronchitis versus pneumonia. And we'll wrap up with 5. The 10 MSRA questions. All right, let's kick things off with Section 1, the bronchitis reality check. What's really interesting about this is the phrase diagnosis of exclusion. Acute bronchitis is a self-limiting inflammation of the large airways, the bronchi. But you can only confidently call it acute bronchitis once you've actually ruled out more sinister pathologies. The hallmark symptom you're looking for is a subacute cough lasting 2 to 3 weeks. That timeline is absolutely critical. Patients will so often panic right around day 10, but as clinicians, we know that 2 to 3 weeks is just the standard expected natural history for this illness. They might also have a bit of mild breathlessness, maybe a wheeze, or even some chest wall discomfort just from the sheer muscular strain of hacking and coughing all day. But generally, it resolves all on its own. Moving right along to Section 2, spotting the red flags. Okay, these are the nice red flags, and I want you to pay really close attention here because here is where most candidates lose points. You absolutely must suspect pneumonia or another alternative pathology if you see any of these. Are they spiking a persistent high fever that's lasting more than just a few days? Are their vitals unstable, showing tachycardia, tachypnea, or oxygen desaturation? When you put your stethoscope to their chest, are you hearing focal signs, things like localized crackles, bronchial breathing, or dullness to percussion? Or, crucially, is the patient showing any signs of confusion or severe systemic toxicity? If any of these are present, you are no longer dealing with a simple case of acute bronchitis. All right, Section 3, antibiotic stewardship and management. So, for your healthy, low-risk patients, the answer is super easy: 0 antibiotics. But what about the high-risk ones? I'm talking about people with pre-existing heart failure, severe COPD, diabetes, or maybe patients over 80 with frailty. For them, we use point-of-care CRP testing, and this brilliantly illustrates the CRP traffic light protocol. Just think of the numbers 20 to 100. If their CRP is less than 20 milligrams per liter, that's a green light. 0 antibiotics, just reassure them. If it's somewhere between 20 and 100, well, that's amber. You give them a delayed antibiotic prescription and advise them to only fill it if their symptoms get worse. But if that CRP is over 100, that's red. You write that prescription immediately. Now, when you actually hit that red light, or when you need to give that delayed script to a high-risk patient, what are you actually prescribing? Just remember the DBA rule. Do bronchitis with doxycycline. Doxycycline is your go-to first-line choice for acute bronchitis when antibiotics are genuinely indicated. Just keep the standard contraindications in mind, which, by the way, we are going to test you on in just a second. Let's move to and see how this builds into Section 4, bronchitis versus pneumonia. Okay, you've got to be able to differentiate acute bronchitis from community-acquired pneumonia, or CAP, literally in your sleep. Let's break this down. Pathogen: bronchitis is viral, CAP is bacterial, typically strep pneumoniae. Systemic signs: well, bronchitis patients generally look pretty well. They might have a low-grade fever or no fever at all. CAP patients, they've got high fevers, rigors, tachycardia. They look visibly unwell. On auscultation, bronchitis gives you normal breath sounds or maybe a diffuse wheeze, but CAP gives you focal crackles and bronchial breathing. Percussion is normal in bronchitis, but it reveals focal dullness in CAP. And listen up, because here is a massive takeaway for your exams. A chest X-ray is not routinely required for acute bronchitis. You only order one if you suspect pneumonia, specifically to look for that focal lobar consolidation.
Okay, home stretch. Section 5, the 10 MSRA questions. Let's do a rapid-fire session.
First up, the basics and the myths. Question 1. A perfectly healthy patient has 10 days of green sputum. What do you do? Reassurance and self-care. Seriously, don't fall into the 10-day trap. Question 8. What's the nice recommended first-line self-care for a 3-year-old with a viral cough? The answer is honey. Yep, simple honey. It's recommended for adults and kids over 1 year old. Question 9. Why exactly is the phlegm dark yellow if it isn't bacterial? Again, that's because of normal neutrophil activity and cellular debris. And question 10, your patient is super anxious at day 14. What's the expected duration? You can confidently tell them the cough can last up to 3 weeks, which is 21 days. All right, next, let's test those high-risk CRP traffic light scenarios. Question 2, a 78-year-old with heart failure has a CRP of 14. Answer? No antibiotics. It's well under 20. Question 3, a diabetic patient has a CRP of 45. Answer? Delayed antibiotic prescription, they're sitting right in that 20 to 100 amber zone. Question 4, a COPD patient has a CRP of 115. Answer? Immediate antibiotic prescription. Perfect application of the traffic light rules. Now for the prescribing traps. Question 5, what is the BNF's first-line agent for high-risk patients who actually require antibiotics? As we learned with the DBA rule, it's doxycycline. But wait, look at question 6. What if that patient is 28 weeks pregnant? Actually, scratch doxycycline. You cannot give it in pregnancy or to kids under 12. The alternative first-line drug here is amoxicillin. And finally, question 7. A patient presents with a high fever, rigors, right-sided pleuritic chest pain, and localized bronchial breathing. What is the single best initial investigation? The answer is to order a chest X-ray. So, the crucial point is this. The very second you hear focal signs or see signs of systemic toxicity, you are stepping out of bronchitis territory and into pneumonia territory. And that, my friends, demands imaging. Well, we have covered some incredible ground today. You now know that acute bronchitis is overwhelmingly viral, you know the CRP traffic light system for those high-risk patients, backward and forward, and you know exactly how to differentiate it from pneumonia. But clinical medicine isn't just about passing the MSRA, is it? It's about the real human sitting right in front of us. So I'm going to leave you with this to chew on. The next time an anxious patient sits in your clinic demanding antibiotics for a 10-day cough, how will you confidently use your new knowledge to explain the 3-week wait and protect them from completely unnecessary medications? Think about your phrasing, own the evidence, and go ace that exam.